Kelly. Dr. Giles, you have the floor.
Honorable Senators, thank you for the invitation to appear today. My name is Dr. Sarah Giles, and I'm the incoming president of the Society of Rural Physicians of Canada. We represent 3,000 physicians and learners who provide care for the 20% of Canadians living in rural, remote, and Indigenous communities. I'm a rural generalist in Kenora. This means I'm the doctor who might round on inpatients in the morning, work in clinic in the afternoon, and be in the ER at night. My hospital provides critical medical care to a town of 15,000 people and to the members of 12 First Nations communities. The lack of connected care isn't a minor convenience. It's a barrier to safe and effective patient care that we see every day. Across Canada, rural community clinics and hospital systems often don't communicate with one another, let alone with regional hospitals or tertiary care centers, which may be in the next province over. The system is effectively disconnected. When I can't see a patient's medical history and information, my ability to provide critical care is impeded, and their life might be at risk while we wait for a fax. Yes, a fax. Consider a patient living in Wabaseman First Nation, that's 1.5 hours north of Kenora, who arrives at the nursing station on reserve with a medical emergency. Let's call her Audrey. Audrey's day-to-day care is provided by a network of non-integrated providers, federal nursing station staff in her community, 3 different local primary care agencies, and specialists in the nearest tertiary care center, Winnipeg, Manitoba. When Audrey arrives at my ER in Kenora, Ontario, I can't see the nursing notes from Wabaseman because their federally managed electronic chart doesn't communicate with the software at my hospital. I can't see the critical lab results because they are physically back in Wabaseman on thermal paper taped to paper charts because they cannot be uploaded into the provincial laboratory database. If there was a doctor in clinic that day, and that's a big if, I can't see their notes because of a lack of local high-speed internet access in Wabaseman. And I can't see any specialist notes or images from Winnipeg because that data stays in Manitoba. Without all that critical information, I have to make the call on how to provide immediate life-saving care to Audrey. Let's say her condition worsens as I wait for this fax to come in. I make the call. We're going to fly her to Thunder Bay, 550 kilometers away. Now, in Thunder Bay, those doctors can see the tests I've ordered if I do a special maneuver with the computer. But again, they can't see anything that's been done in Wabaseman or Manitoba. So investigations and consultations are repeated. When Audrey is discharged, maybe she'll be okay. Or maybe her prescriptions and follow ups will be missed because the systems don't talk to each other. And in a month, Audrey just might be back at the nursing station, but in worse shape. This is because our systems can't communicate. The lives of people like Audrey are at risk every day. Imagine instead if healthcare worked like banking, if Audrey had a card that allowed her electronic chart to be updated in real time anywhere in Canada, to be visible to any authorized provider anywhere in the world. We have the technology to move money. Now we need it to move medical data. Rural physicians don't just want new software. We need an interoperable system that can quickly give us access to a patient's correct medical history, that eliminates expensive, time-consuming duplication of our work for things like consultations, tests, and imaging, and ensures patient follow-up. Let me be clear. The federal government is the only entity with the power to fix this problem. This needs to be an evidence-based, coordinated, and well-resourced effort across the country. The push for interoperability must be sustained and maintained with improvements benchmarked against the level of patient information sharing now and progress assessed every 2 years thereafter. It's also critical that the money for telecommunications infrastructure, like basic high-speed internet, be included. The lack of high-speed internet in the North threatens the fundamental goals and potential of this bill. 40% of rural and remote communities lack access to high-speed internet, and the workaround in medicine is to use the fax machine. Yes, I'm back to talking about fax machines. We can design the best programs and software in history, but it won't make a difference if rural and remote patients can't connect it to the patient data. Senators, you have an opportunity to improve the health outcomes of rural patients and, to be blunt, save lives. We encourage you to pass Bill S5 and ensure that the government builds an effective system that will ensure that a patient's medical history follows them whenever and wherever they seek care, and that the high-speed internet access is also there. Without this integration, we are setting both physicians and patients up for failure. Thank you.
Thank you very much,